inflamed, right? And another thing, yes, aortitis, right?
Yes.
Hello. So inflammation
Yeah.
of aorta is also going to be seen. And we already discussed, if you guys remember aneurysm, we discussed aneurysm, right, in our CVS module. What was the main cause of aneurysm? We discussed that is weakening of your aorta, right? And as a result of that, your vasa vasorum cannot supply your aorta, and once it become weak, it would just end in a balloon-like dilatation, which is simply known as aneurysm, right?
Yes, that's correct.
So can I say that whenever we have aortitis or inflammation of aorta, it would lead to aneurysm, aortic aneurysm, right?
Yes, sir.
Yes.
Okay. For example, if the aorta involves the root, like for example, if the root is affected, we already know there is a valve, aortic valve present, right? So if you are dilating the aorta, what happens now? Both of these aortic cusps cannot close with one another, and it would lead to regurgitation, right?
Mm-hmm.
And regurgitation is associated with which murmur? Yes. Aortic regurgitation.
Diastolic.
Okay, diastolic murmur. What's the specific name? Is it a hollow systolic or it is a decrescendo?
Decrescendo.
The decrescendo.
Decrescendo. Yes, decrescendo murmur. So, for example, in your UWorld, if you guys see a question, if an individual is having a decrescendo murmur, some eyes problem, and some back pain, so simply you can think of it's seronegative spondyloarthropathy, and specifically it is ankylosing spondyloarthritis. And whenever you see the word bamboo spine, just go and choose this answer. Is that clear?
Yes, sir.
Okay, so the next pathology which comes under the category or group of seronegative spondyloarthritis, what's that? That's Reiter syndrome. Yesterday, Dr. Maheen, gave you a little bit idea of Reiter syndrome, right? So in order to, remember Reiter syndrome, there's a mnemonic that this individual can't see.
Can't speak,
Yes.
can't climb the tree.
Yes, can't see, can't climb the tree,
And
can't pee, right? Yes,
Yes.
can't pee. So it means we are going to see three things in Reiter syndrome. What are that? Yes, if an individual cannot see, so simply you can think of there is some conjunctivitis going on, right? Inflammation of conjunctiva would ultimately lead to blindness, right? Can't climb the tree. It means like it's this in this pathology, we are also going to see some joint problems, right? If you have joint problems, you can't climb the tree. That's simple, right? And can't pee. It means there would also be some inflammation of your lower urinary tract. And what's that? Urethritis, right?
Yes, right.
Okay, we discussed urethritis. If you guys remember in our renal section, what's the two bugs which causes urethritis?
Chlamydia.
Okay, chlamydia and
Gonorrhea.
Gonorrhea.
right?
Gonorrhea.
Okay, so both of these can cause urethritis, but here the chlamydia trachomatis is the main bug which you guys should just take it into consideration. Is that clear?
Yes, sir.
Okay, so the next pathology which we are going to discuss is psoriatic arthritis. Psoriatic arthritis. The idea is really simple. We have a dermatological condition which is known as psoriasis, right? We'll be discussing that in derma section in our minors, right? So we will be discussing dermatology in our minors. That is the second phase of preparation. So sometimes these individuals can also have arthritis, which is simply known as psoriatic arthritis, right? Like
Yes.
10% of individuals who are having psoriasis, they can also develop arthritis, right? So it's a big, number, 10%, right? So like there should be a specific pathology, a specific name for that, right? So that is psoriatic arthritis. That's simple, right? But an important feature which you guys have to remember, which is specific for psoriatic arthritis, is that this arthritis can also involve DIP, or distal interphalangeal joints. And once that are involved, what happens? Your foot or your fingers or your toe would just resemble like a sausage, right? Like for example, normally we have like well-defined fingers with these joints, but if these distal interphalanges are inflamed or there is any pathology, so it would appear as a sausage finger, right, or toes. Is that clear? So whenever in the UWorld you see like a condition having some kind of psoriasis, like any skin condition, and along with that, the fingers of your your hand and toes are like just like sausage, think of psoriatic arthritis going on there, right? Is that clear?
Yes.
Okay, that's perfect, right? So our next pathology which we are going to discuss is gout, right? I think it's like, I would say, highest yield pathology, and you have a lot of MCQs in your world. So let's break this pathology down, right? So what is gout? What do you guys, like, think of whenever you heard the word gout, whenever you hear it?
Increase in uric acid.
Perfect. We have increase in uric acid. What would happen next? Uric acid is going to deposit in joints, right?
Yes.
Yes, sir.
Or as a crystals, right?
Yes, sir.
And once uric acid is deposited in the joints as a crystal, it would lead to inflammation of your joints, right? Hello?
Yes, sir.
And inflammation can give you a lot of problems, right? So if the main concern here is hyperuricemia or increased uric acid, right? So for that, we should also know that how do uric acid increases? Like, a little bit physiology of that, right? So we know that uric acid basically comes from purines metabolism, right?
Yes.
Okay. We know that where do purines come from? From your DNA, right? Is that clear?
Yes.
Okay. Can you just tell me like two kind of purines, that is AMP and GMP, right? These are your purines, right?
Yes.
Okay. So what happens normally that these purines like AMP would be converted into, yes, anyone? What's the next step?
Inosine
Guanosine and
Guanosine
Okay, it would
monophosphate.
just convert into guanosine, right? What about AMP? You guys are going to tell me that.
inosine.
adenosine.
Okay, adenosine, right?
Yes, sir.
Yes.
Okay. And right after that, both of them are going to be converted into hypoxanthine. Am I right?
Yes.
Yes.
Okay. Hypoxanthine and then into xanthine or hypoxanthine?
It's to
Hypoxanthine.
hypoxanthine and then to uric acid.
Okay. So, and ultimately it would be converted into uric acid, right? But an important point which you guys have to remember that we have another enzyme that is known as HGPRT, right? So normally what HGPRT do, HGPRT would just take them and it would just regenerate them, right? So if HGPRT is regenerating both your adenosine, okay, is it an adenosine? Just confirm it, right? Okay, and guanosine. So what happens that if your HGPRT is, regenerating them, it means that the level of uric acid normally is going to be gone down, right? If the activity of HGPRT increases, it would decrease uric acid. Can I say that?
Yes.
Okay. On the other hand, can I say that if the HGPRT is not present, if you have some problems with this enzyme, you're going to have a lot of uric acid.
Yes.
Can I say that? Okay.
Yes.
Another thing which you should just keep in mind.
Doc,
Yes,
can you
please.
just go again with the AGPRT concept, how it is regenerating and causing the changes in uric acid?
Okay, it's basically a topic of your biochemistry, but here you have a NBME MCQ basically on that concept, right? It's a very important concept. We'll be discussing the details in our purine metabolism in our biochemistry, but I want to just give you a brief overview of that, right? Normally, what do HGPRT enzyme do? It would just take adenosine and guanosine again, and it would just regenerate them, right? Hello?
Yes.
Yeah. Okay.
It would salvage them. You have a pathway which is known as salvage pathway, right? So it would just take adenosine and guanosine, it would salvage them, and in turn, your uric acid is going to be dropped down, right? It's very helpful. Is that clear? But if we have problems with this enzyme, if an individual is deficit with this enzyme, can I say that he can have increased uric acid now?
Yes.
Or if he have increased uric acid, can I say it can lead to gout?
Yes.
Okay, perfect. So basically you have two types of gout, right? That is primary gout and secondary gout. In primary gout, basically you do not know the mechanism. Why do we have increase in uric acid? But the secondary gout, we know what's happening. Like what thing? Sorry. In secondary gout, we have an idea that it can be due to a syndrome which is known as Leach-Nyhan syndrome. What is Leach-Nyhan syndrome? We already know that whenever you do not have HGPRT. Let me just name it as Leach-Nyhan syndrome, right? Is that clear? So can I say that if I have a Leach-Nyhan syndrome, what happens? I do not have HGPRT. If I do not have HGPRT, we cannot salvage your adenosine and guanosine, right? And if we cannot salvage them, what happens? All of the remaining adenosine and guanosine can be converted into uric acid. Can I say that? And it can lead to gout.
Yes.
sir.
Okay, so Leach-Nyhan syndrome is basically X-linked deficiency of the HGPRT, and HGPRT basically stands for hypoxanthine guanine phosphoribosyl transferase, right? Hypoxanthine guanine phosphoribosyl transferase, right? HGPRT. Just simply, remember it as HGPRT. Is that clear?
Yes, sir.
Yes.
Okay, so let me just repeat the concept again. We have AMP, we have GMP. It is going to be converted into adenosine, as you guys just told me. I'm still not confirmed about that. This step, just look for that. And guanosine, right? But in the end, you have hypoxanthine, and ultimately it would be converted into uric acid. What do HGPRT do? That's salvage adenosine and guanosine. If I have deficiency of HGPRT, that's simply known as Leach-Nyhan syndrome. And if HGPRT is deficit, what happens? The process, or the steps can go further. It can lead to increased uric acid and in turn gout. Is that clear?
Yes.
Okay. Another point, as we know that uric acid comes from purines, right? Can I say that?
Yes, it's disorder. Urine.
Yes, perfect. And purines in turn come from DNA, right? So can I say that if I have any process, like for example, if I have increased cellular turnover, cells have a lot of DNA. If I have increased cellular turnover, it can also lead to a lot of uric acid, like a lot of purines, and these purine in turn can be converted into uric acid. Can I say that?
Yes, sir.
Yes.
Okay, perfect. So if I have increased cellular turnover, again, I will be having increased uric acid, right? And in which condition do we have increased cellular turnover? You already know that, leukemia and myeloproliferative disorder, right? So in leukemias and myeloproliferative disorder, we already discussed that it can increase the risk of gout, right? Another thing, third thing, we know that whenever the uric acid develops, normally our body filters it out through kidneys, right?
Yes.
Yes, sir.
So can I say that if I have problems with kidney, let's suppose CKD, again, it can increase uric acid levels, and again, it can cause gout. Can I say that?
Yes.
Perfect. That's perfect, right? So we discussed gout. What is gout? It's like a deposition of your uric acid, and it's specifically monosodium urate, right? Monosodium urate crystals within the joints. Once we have those crystals in the joint, it can cause inflammation there. It can cause problems, right? From where do uric acid come? You already know, DNA, or specifically purines, right? So we have two types of gouts, right? Primary or secondary. Primary, we do not know the cause, but for the secondary, we know the causes, because we know the entire biochemistry of that, right? We know HGPRT helps in salvaging your intermediate step, that is adenosine and guanosine. If we have deficiency of HGPRT, that's Leach-Nyhan syndrome, and it can cause gout. Secondly, we discussed that if we have increased cellular turnover, if I'm just turnovering cell again, like more, it means that you're going to have a lot of DNA, a lot of purines, and a lot of purines can add into a lot of uric acid. Is that clear? Which can in turn cause gout,
Yes.
right?
Yes.
And the third thing we discussed, if although we have increased uric acid, it's the job of your kidney to eliminate that, right? So if you have problems with the kidney, again, uric acid can develop, which can cause gout. Is that clear?
Yes.
Yes.
Yes,
Okay.
sir.
So what would be the presenting feature? Yes, it's very high yield and specific to this pathology. Do you guys know podagra? No.
Yes, sir.
What is podagra?
Tophus formation.
Yes,
Yes.
tophus.
Okay, perfect. Toe formation, right? But it's specifically in your great toe. Whenever these monosodium urate crystals, they love to, simply you can think of, they love to first of all, invade your great toe, which can cause, arthritis, painful arthritis of your great toe, which is simply known as podagra, right? Is that clear? Okay. So monosodium crystal deposit in the joint, and we already know once they are deposited, they are going to trigger inflammatory process, right?
Yes.
Okay, you have another UWorld MCQ. What else gout is associated with, apart from them? Yes.
Excess alcohol.
Perfect. Excess alcohol, and specifically beer, right? Because what's the concept for that? Simply you can think of that the alcohol also just try to they're also eliminated by your kidney, right? through same receptor where your uric acid is going. So if you have a lot of alcohol, it would just compete with the uric acid. And if alcohol is moving out, so uric acid would just build inside your body. Is that clear?
Yes.
Okay. So you have a U-word MCQ. They are simply going to ask you this, right? Beer. So the answer for that is beer. Just mark that from my side. Okay. 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 So this was all about acute gout. Gout can sometimes lead to chronic gout. So what is chronic gout? As Dr. Abdurrauf just told us, chronic gout, that these uric acid aggregates which we discussed, or the crystals, they can transform into a structure which is known as tophi, right? So what are tophi? Yes. Yes. Hello. Why aren't you guys
Aggregation.
participating?
Uric acid. Aggregation of uric acid with fibrosis.
Okay, perfect. If it's a chronic process, we already know that chronic process in the end leads to fibrosis. We are just, no, we already know that. We discussed it a lot of time. Chronic inflammation or chronic, problems cause, in the end, you have regeneration or which leads to fibrosis, right? So tophi are simply white, chalky aggregate of that uric acid, right? Accompanied by fibrosis. Whenever you have fibrosis, and you have like a giant cell kind of reaction there as well, right? So simply what are tophi? Basically, it is seen in chronic gout, and whenever this uric acid converts into white chalky aggregates along with fibrosis, that's known as tophi, right? Is that clear?
Yes.
Okay. Okay. Apart from that, what do you guys think that like how to confirm whether we have these urate crystals? Yes.
Should it be the negative birefringent just on polarized light?
Okay.
And
So
over
they
analysis,
are negative birefringent or positive? First of all.
negative.
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 Okay,
Negative.
perfect. They are negative birefringent. And what's the concept for that? The concept is very simple. Just take these crystals. As you guys are already aware of, you already did a lot of physics in our preschool, right? So we already know that whenever the plane polarized light is passed, what is plane polarized light? That's simple. Whenever normally we know that light is like traveling in a lot of axes, right? What is plane polarized light? If you just take a one axis light, right? If you just block off the entire axis and you just take a simple axis light, or it's not like it's moving in a single axis, that's simply known as plane polarized light, right? So whenever plane polarized light passes through the crystals, the crystals have they have that intrinsic ability to cause diffraction, yeah, right? Or bending of the light, refraction.
Yes.
Right?
Yes.
So what would happen in the end if you just place these crystal perpendicular? So in the end, which color are you going to see in negative birefringence? I am discussing perpendicular.
Should it be yellow?
Yes. Yellow. I think it's blue.
Green.
Blue. Blue.
That's blue.
Blue. Yeah.
Perpendicular, it would be blue. But if you just place it parallel
Then
and
yellow.
just pass the
It's
plane polarized light, that would be yellow. Right?
Yes, sir.
Okay, let me just tell you again. What is the concept of birefringence? Just check plane polarized light. What is plane polarized light? Light traveling in a single plane, in a single axis. Okay, we already discussed they are monourate crystals. So crystals have the ability of refraction, right? That would block all of the, we know the different wavelengths of light. So it would only let blue wavelength once it's perpendicular in axis. So your only blue wavelength light can be reflected back. So that's why the crystal will be appearing blue whenever it's perpendicular. Is that clear? But when the same crystal is taken and is placed parallel to this light, it would, reflect which wavelength light? Yellow wavelength light. Is that clear?
Yes, sir.
Okay, that's perfect. So we also have another condition which strongly resembles with this, that is known as pseudogout. What do we mean by pseudogout? Pseudo means
Imitation.
false, right?
Yes, false.
So the term pseudo means false gout. So
False.
how can one have false gout?
These are the calcium pyrophosphate.
Perfect. These are also crystals. They also deposit in joint, which can cause inflammation. But here they aren't monosodium urate crystals. They are basically calcium pyrophosphate Dihydrate crystal, right? Or CPPD, right? Okay, another thing, they are needle in shape, right? What's the shape? Needle shape, right?
Yes, sir.
Yes.
Okay, perfect. And what about CPPD? They are rhomboid. Okay, like although the mechanism is simple, you again have crystals which can cause inflammation there, which can give you problems, right? But here it's due to calcium pyrophosphate dehydrate, right? Dihydrate, sorry. Okay. So and what's the next differentiating feature? They are positive birefringent. What is positive birefringence?
That is, they're gonna give the blue color light.
Okay, perfect. Again, you would just take plain polarized light and just hit the crystal, the rhomboid shaped crystal, I would say, right? So what happens in perpendicular, it would reflect yellow wavelength light, right? And if these crystals lay like, in parallel to this plain polarized light, what would happen? You're going to see blue color. Is that clear?
Yes,
So it's
sir.
like opposite to negative birefringence. That's all about gout and pseudogout. Is that clear?
Yes, sir.
Okay, perfect. So let's discuss our next pathologies that are basically related to your skeletal muscles, right? Skeletal muscles. So the first pathology which we are going to discuss is dermatomyositis. Dermatomyositis, right? So let's break the name. What do dermato means and what do myositis mean? Can I say that dermato means that in this pathology you are going to see some problems of the skin, right?
Yes.
Correct. Yes.
Some skin problems. And myositis, it's simply inflammation of your muscles, right?
Yes.
Okay, perfect. So we already know that in dermatomyositis, we are going to have inflammation of your muscles. But an important feature which you guys should just keep in mind whenever you see dermatomyositis, it's highly associated with a carcinoma, right? So if a patient appear in a clinic complaining of dermatomyositis, like if you just diagnose him with dermatomyositis, I'll be telling you how to diagnose it, right? So you should also be thinking of cancer, right? And specifically gastric cancer. Is that clear? Gastric carcinoma. Hello?
Yes, sir.
Okay, what would be the clinical features? Let's come to the clinical features. So if we are going to see inflammation of muscles, which muscles are going to be affected? The proximal muscles. What do we mean by proximal muscle? Like the muscles of your shoulder, muscles of your hip, they are proximal muscles, right?
Yes, sir.
Okay, so the proximal muscles can be affected, right? So in the clinical venient, you can also see an individual, for example, if you're just suspecting him of having, dermatomyositis. So one of the complaints which he'll be doing is that he cannot comb his hairs, right? Because combing hairs, you need movement of your shoulder, right? Or proximal muscles. Can I say that?
Yes, sir.
So it's difficult for them to comb hair, right?
Yes.
It's difficult for them to climb even on the stairs because again we are using proximal muscles, right, for that.
Yes, sir.
Okay, so it's basically an inflammatory disorder, and what's specific about it, you are going to see bilateral involvement of the muscles, right? Bilateral involvement. Is that clear?
Yes, sir.
Yes.
Okay, perfect. So as we discussed in the muscles, proximal muscles are involved, but here we also discussed that we are also going to have some skin problems. So let's discuss what skin problems are associated with dermatomyositis. So, okay, can you guys just tell me some of the...
Rash,
Heliotrope.
Okay,
eyelids.
perfect. So rash on his upper eyelid, right, which is known as
Rash. Yes.
heliotrope rash, right?
Rash.
Perfect. Yes. And what about the next malar rash, right?
Calcium deposit.
Yes, perfect. Malar rash, right? And the third one, you can have red papules on the elbow, knuckles, and knees, right? So you're going to see three things. 1, 2, and 3. Red papules on your elbow, knuckles, and knee, which are also known as scrotum region, right? Okay, that's perfect. But if you guys remember, we were also seeing malar rash in another pathology. Do you guys remember?
Yeah, SLA.
That was specific for SLE, right? Okay, let me just discuss some of the lab finding. In the lab finding in this individual, you are also going to see positive ANA, right?
Yes.
Okay, so if a patient appear having a malarious and positive ANA, so that's also common in SLE. What do you think? How would you, like differentiate both of these pathologies?
Do specific tests for SLE, anti-DNA, and anti-Smith.
Okay, perfect. So for SLE, we are going to do like, we already know that we are going to have anti-DNA and anti-Smith, right? And what about dermatomyositis?
Anti-Jo1.
Perfect. So you are going to have an autoantibodies that is anti-Jo1, right? Jo1 antibody, right? Right? And it's highly specific for dermatomyositis, right? Okay. So can you guys just tell me, we already discussed we are going to have inflammation of proximal muscles. Let's just zoom in this picture, right? Let's zoom in the picture. So for example, if I have a proximal muscle, let's suppose in the muscles you have a lot of fibers, right? Like our fascicles kind of things, right? And in between you have a connective tissue, like in the periphery that is known as perimysium. And in between these fibers you have endomysium, right? Right? So can you guys specifically tell me that this inflammation is going to be involving your perimysium or endomysium?
Perimysium.
Perfect,
Perimysium.
perimysium. And
Skin.
how to remember that? The idea is really clear. It's dermatomyositis, derma, right? Skin. So skin is present like somewhere here on the top, right? So you're going to see involvement of perimysium here, right? Because endomysium, we are going to discuss our next pathology, and there we have inflammation of our endomysium. Is that clear?
Yes,
Doc, can I just-
Okay, and if it's inflammatory, which inflammatory cells will be seen?
CD40.
CD4.
Perfect.
CD8.
CD4.
Okay, no, not CD8, CD4. CD8 is like for the next pathology which we'll be discussing. Okay, that is polymyositis, right? Okay, so can you guys just tell me if this pathology is carried by your inflammatory cells? So what should be the treatment?
Corticosteroids.
Steroid.
Perfect. Just give them corticosteroids. All of these inflammatory cells are going to, they're going to like decrease, right? So you're just suppressing the immunity, suppress the immune cells, and this pathology can be treated, right? So corticosteroids would be helpful. Is that clear? Okay. So who is going to give me overview of this topic? Yes. Please raise your hand, those who want to give me overview of this topic. Okay, doctor. Okay, okay, Dr. Ramiz, Dr. Gyanchi, Dr. Muskan. So Dr. Ramiz, can you just please tell me a little bit about this pathology?
So should we start from like where? Gout?
No, just start from dermatomyositis.
Oh, okay.
Yeah. So we are studying the pathologies of the skeletal muscles. So dermatomyositis, as the name suggests, that dermato means there is some skin involvement, and myositis means there is inflammation of the muscles. And it is highly associated with cancer, specifically the gastric cancer. Now, clinical presentation for the muscle part, there will be bilateral proximal muscle weakness. So the patient will find it difficult to comb hair and climb. And for the skin part, there will be like a rash on the upper eyelid, that is heliotropic rash, malar rash, and red papules on the knuckles, knees, and elbows, that is Gorton papules. Okay.
Okay, perfect. Gotten lesion.
Yeah, and there is another condition known as SLE, where we find and the lab for dermatomyositis is ANA positive. Now, confusion usually like comes like there is another condition called SLE, which is also ANA positive, and there is presence of malar rash. So we will differentiate these two conditions by another test, that is anti-Jo1 is present in positive in dermatomyositis, and anti-dsDNA is positive in SLE. And the last thing is that there is involvement of the nerves that causes the proximal muscle weakness, and there is the involvement of the perimysium by the CD4 positive T cells.
Okay, perfect. So we have another pathology that is like almost same as this dermatomyositis, that is known as polymyositis, right? So it's same as dermatomyositis, but you do not see the word dermato, right? So it means that what's the difference between dermatomyositis and polymyositis, as we do not have the word derma, so it means no involvement of skin, right?
Yes.
No involvement of skin is seen here, right? Okay. Another differentiating feature again is myositis, inflammation of your muscles. But we have to zoom in the picture where we are going to have inflammation. We discussed
Endomysium.
it would be
Endomysium.
endomysium. Perfect. Endomysium, connective tissue in between those like muscle fibers, right? Endomysium. And what else? If their CD4 cells were causing problems, their CD8
88.
CD8.
CD8 positive cells are causing problem. That's all, right? So like again, you have like proximal muscle involvement. Each and everything is same as that of your dermatomyositis, but no skin involvement, inflammation of endomysium and CD8 positive cells. Is that clear?
Yes, sir.
Okay. So the next pathology which we are going to discuss is X-linked muscular dystrophy, or also known as Duchenne, right? X-linked muscular dystrophy. Okay. So what do you guys think? What happens in X-linked muscular dystrophy? Yes.
Only male. Oh, sorry.
Okay. So the main idea of this pathology is that it's like due to some like mutation of a gene which is known as dystrophin gene, right? It's mutation of a gene, dystrophin,
Only.
right? Okay. So what is basically the molecule dystrophin, right? Anyone who knows? Hello? Hello?
Is it DMD gene?
Okay, yes, the gene is, yes, that DMD which you are talking. But as a result of mutation of that gene, you are going to have problems with the molecule which is known as dystrophin, right? So, okay. What's the main idea of, okay, what's the importance of dystrophin? Remember that, for example, if this is our like a muscle cell, right? And in the muscle cell, we have like, you know, microfilaments, right? So what does the dystrophin basically do? Dystrophin basically anchors these, anchor the microtubules within the cells with the extracellular matrix, right? So this is the function of your dystrophin molecule, right? Okay. So whenever we have like X-linked mutation which lead to like problems within the dystrophin, what happens? It would lead to degenerative disorder, right? So the muscle itself is going to degenerate. Remember that, right? So it's a degenerative disorder. If you have problems with dystrophin, the muscles is going to degenerate, right? And after this degeneration, remember, when the muscle is degenerated, you do not have muscles. So that space of muscles where priorly we were having muscle, that is going to be filled up with fats or adipose tissues. Remember, right?
Yes.
Is that clear? So in X-linked muscular dystrophy, it's a degenerative disorder in which we are going to see muscle wasting and replacement of that skeletal muscles by adipose tissue. Why do we see that? We already know, due to mutation of dystrophin, right? Hello?
Yes.
Yes.
Or
Doctor, can you just repeat, like it binds the T tubule, which what structures?
okay, so we have microtubules within your muscle cells, right? Extracellular matrix, right? Your extracellular matrix. Like simply you can think of it's a kind of pillar, right? Which is, you know, like maintaining the integrity of your muscle cell, right? If this pillar is lost, if you do not have anyone to anchor them into extracellular matrix and hold these microtubules in, you know, in position, so what would happen as a result of that? As a result of that, your entire muscle can degenerate, right? And in the end, that degenerated muscle is going to be replaced by adipose tissues because you need something to be replaced, right? So adipose basically do that, right? It replaces the waste muscle. Is that clear?
Yeah, got it.
Okay. So, okay, what would happen to serum creatinine kinase in this condition? What do you guys think?
It should increase.
Yes, serum creatine kinase is basically present in your muscles, right?
Yes.
So if you have problems with muscle, would it increase or decrease?
Increase.
Yes, it would increase. If you have degeneration, all of this enzyme will just come out. Simply you can think of, you can just, you know, relate it with, you know, TROP-I and the CKMB which we discussed, right? So this was all about X-linked muscular dystrophy. And the last topics which we are going to discuss is Myasthenia gravis and Eaton-Lambert. We already have discussed those in our various modules. You know, if you guys remember.
Can I just recap about this last subject?
Okay. So, okay, let me just recap it. We have a condition which is known as X-linked muscular dystrophy. What happens in that? We have mutation of dystrophin molecule. What is dystrophin molecule? Dystrophin molecule basically anchors the inside microtubule of your muscle cell with the extracellular matrix. Like simply you can think of, you're just tying the muscle cells, right? You're just tethering them with the extracellular matrix so that they can be in their proper position, right? If this tying of your muscle cells is not present, or in other words, if you do not have dystrophin, what would happen? The muscle would get degenerated, right?
Yes.
Hello? Okay. And once a muscle get degenerated, it would be replaced by adipose tissues. Is that clear? So whenever we have mutation,
Yeah.
okay, that's basically a spontaneous mutation, right? So like basically the genome for the genes which encode for dystrophin, there's a big genome for that, right? So we can have spontaneous kind of mutation there, right? Because due to its big structure or big genome, right, which is encoding for the dystrophin, right? So as a result of that, we are going to end in a condition which is known as X-linked muscular dystrophy. Is that clear?
Yes, clear.
Okay. So the next topic which we are
Is
Sorry?
there any kind of treatment for X-linked or not yet?
Okay. So basically, I would say that there isn't any specific treatment for that, because like if the muscles is losing and if you have a genetic problem, so it can be fatal, right? It can spread like distally as well, right, with time, and it can ultimately cause death. So there isn't a specific treatment for that. Is that clear?
Yeah,
Yes,
thank you.
Okay, perfect. So let's discuss our next topic, that is myasthenia gravis. So we have discussed myasthenia gravis, in our respiratory section. If you guys remember, small cell lung carcinoma, paraneoplastic syndrome, remember? So I want you guys to tell me about myasthenia gravis, right? So I'll be just, I won't be writing anything, and I'll be asking from you guys. Those who want to participate, please raise your hands.
Can I participate?
Yes, please. Dr. Satrov, yes.
Yeah.
Okay, first of all, what is myasthenia gravis? What do you think?
It's just a chronic autoimmune disorder.
Okay, if it's an autoimmune disorder, it means that you want to say that we'll be having some antibodies against our, our own tissues or our normal receptors. So what do you think? Which antibodies against which receptor are we going to see in this condition?
Postsynaptic acetylcholine.
Acetylcholine.
Perfect.
Acetylcholine
Postsynaptic acetylcholine. So Dr. Gyamshi, if we have antibodies against postsynaptic, acetylcholine receptor, so what would happen as a result of that? Yes.
You can so the antibody acetylcholine is not released. So that's progressive fatigue.
Acetylcholine is coming, but it cannot, bind to the receptor because already the antibodies are sitting there. Can I say that?
Yes, sir.
Yes.
Yes.
Right. So acetylcholine would just come out in the synaptic cleft, but it cannot undergo its normal, action, right? And what's the treatment? Acetylcholinesterase. If I'm increasing the concentration of acetylcholine, so there is a chance that acetylcholine can knock off these antibodies off the receptor and perform their normal action. Can I say that?
Yes, sir.
Yes, sir.
Okay, perfect. So, okay, if you guys remember, we discussed it's highly associated with which thing? We discussed it like I would say 5 to 6 times.
Thymoma.
Thymoma. Perfect. It's associated with thymoma. So sometimes if you just treat the thymoma, this condition can be subsided, right? Okay. Another thing, can you guys just tell me, like with, for example, if I'm using the muscles, so with usage of my muscles, would this condition, worsen, or it would,
Worsen.
worsen, right? With the usage,
It will improve with rest.
Yeah.
yes, improve with rest and worsen by using your muscles. Why? Why? What's the reason behind that? What do you guys think?
Because of the decrease of the acetyl-CoA, like the usage.
Perfect. Right. So if you are using muscles again and again, so you know that your neurons can also just become fatigued, and ultimately they'll be dumping off less acetylcholine. So if you have with use acetylcholine which is being released into the synaptic cleft, it will be decreasing in concentration, and there is decreased chances of knocking off your antibodies, right? So in this way, you'll be seeing worsening of this condition with use, right? And if you are just resting, you are giving rest to your neurons, it can have a lot of acetylcholine then, and in turn it can lead to, again, proper working. Is it clear?
Yes.
Yes.
Okay, perfect. Okay, so there is another.
Can you repeat that? Why it get worse? I did not get that concept.
Okay, so I think that we have to just come again to whiteboard for that, right? So we discussed that, for example, if it's a postsynaptic neuron, okay, presynaptic and postsynaptic, right? So we have acetylcholine receptors, right? Let's suppose, right? And we have, let's suppose, antibodies sitting on these receptors, right?
Yes.
Okay, so what happens? Acetylcholine is just coming out, but it cannot, you have antibodies sitting over there on the receptor, so it cannot undergo its proper function, right? But if I'm just giving rest to this neuron, so rest, what would happen as a result of rest? You will be having a lot of acetylcholine, right, with rest.
Yes, sir.
And if I'm just using muscles again and again, so with time what happens? The acetylcholine, you are dumping acetylcholine. So for example, if initially it was just throwing 100 molecules, so right after using or muscles or contracting 5 times, it would just come to 95, right? I'm just getting,
yes.
For example, if I'm just using muscle 10 times, it would just come to 80, because you're just using the things, you are just using these sacks of acetylcholine, right? And for example, with 30 use, let's suppose it's now 50, right? So 100 can still compete. There is still chance of knocking off these antibodies and attaching to this receptor and functioning, right? But as I'm using muscles, I'm decreasing the number of, or the total number of your acetylcholine. So with decrease in the number, there is decreased chances of knocking off your antibodies from the receptor. Is that clear?
Yes, sir.
Perfect.
Yes.
Yes.
Okay, perfect. So we have another pathology which is known as Eaton-Lambert syndrome. First of all, you guys are going to tell me what's the association. We'll discuss in the respiratory section.
Small lung carcinoma.
Small cell lung
Perfect. Small cell lung carcinoma. Okay, so we discuss again, we have our presynaptic neuron or postsynaptic neuron, right? And here we have our calcium channel. So in order to release your acetylcholine, we need calcium influx, right? But what happens in Eaton-Lambert or Lambert-Eaton? You have antibodies against
Calcium.
Yeah.
Synaptic calcium.
calcium. Perfect. So it means
Unable,
that what happens?
unable to release acetylcholine.
Perfect. I'm able to release acetylcholine. But another thing, if I'm just using the muscle, what do you think with using my muscle again and again or contracting, what would happen? The condition would improve or not worsen? What do you guys think? Improve. Perfect. And why is that so? If I'm using muscle again and again, it means I need, a lot of calcium are going to come. A lot of calcium are going to come if I'm using it again and again, because I need calcium influx. So if I'm just contracting it like 5 times, let's suppose 10 molecules come, right? If I'm just contracting it 10 times, the molecule number would increase. The molecules or the calcium would increase. Let's suppose 20. So now as the number of calcium ions are increasing, so there is more probability to knock off these antibodies from the calcium channels, and the calcium can enter inside and can release acetylcholine. So with using muscles or contracting muscle, this condition is going to be improved. That's all. Is that clear?
Yes.
Perfect, right? So
Yes.
it was all about today's lecture. Tomorrow, you guys have your workshop on research. Kindly participate in that. You guys already have seen, we have just invited Dr. Abdullah. He's currently training in Mayo Clinic. We have Dr. Menahel. She have a lot of publications. We'll be just, revealing each and everything. Everything is going to be in front of you. But I want you guys to participate in research from now, because I have just told the team, okay, tomorrow we are going to have bootcamp session. First of all, we'll be having our research workshop. It will be like for 1 hour, right? And right after, why are you guys crying? What happened?
It's going to be very, very tight day
Yeah,
tomorrow, from what you're saying.
we are already in the in the end of our preparations. We are only left with GI, Neuro, and Repro, right? Only 3 systems. So you guys have to be mentally prepared for that, right? That now the schedule is going to be very tough, because in the second phase of preparation, we'll be having a bootcamp session on daily basis, because we are going to revise all of your course, right?
Yeah.
Yeah. So you will be expecting daily bootcamp session. So just get prepared for that, right? So, okay. So no free day. No free day. If you guys remember, I just gave you 1 day for revision, right? That was your free day. Whenever I just tell you revise your course, think of that's your, a free day, right? Okay. Another thing which I want to mention, that I just told the research team that they're going to take things like slow, right? So that you can prepare for your step 1 as well. And you do not miss the opportunity of participating in meta-analysis. Why? Because meta-analysis at least take 4 to 5 months, right? So if like what happens most of the time that once the students are done with step 1 and step 2, in the end, when they came to know about like whenever they apply for the match, they came to know that now we have to do research. So they again waste 2 to 3 years for that, right? Are you guys getting me? Because at least you need 4 publications, right? And 4 publications need like 2 years. And meta-analysis is the one which is considered more. So it's the best time for you guys to participate in that, right? Hello?
Yes.
Yeah, thank you so much.
And for that, like we have kept the charges too low for everyone because we are only like we are just paying to the best team which is like out there, right? So like Dr. Abdullah and Dr. Mahin, they are not only going to tell you, they're not only going to educate you on research, but they'll be also giving you and helping you in the end to get your first publication. Like they'll be there, they'll be just doing a kind of live research on you guys. They'll be giving you tasks, how to extract data, how to use different softwares. So we have just kept like a minimum charges for that in order to, you know, like just pay for these professionals. That's simple, right? So I want you guys to participate in that because if after the step 2, we are soon going to launch second marathon. So you should not, you know, waste that 2 years of gap right after your step 2 exam, because you guys know in the match, okay, we will be completing the whole marathon, like approximately including everything. Okay, yes, on the 20th April, we'll be completing each and everything along. Everything will be done, like revision, the minors. Okay, so what's your question? Please turn on your mic. Hello, any questions? Okay, how many hours per week engagement for the research? So for the research, you're only going to give like at least 30 minutes or 20 minutes per day, not more than that. Is it right? No? Yes.
Yes, sir.
Yes.
Okay, Devanshi, yes.
Like, is it still possible to match for this cycle if I give exam in May, like step 1 in May, with
Okay, so for
research and
you
everything?
guys, yes,
Because
so for
I'm
you
an
guys,
old graduate and this is my fifth year. Like they say,
oh,
like under 5 years of biology.
okay, so we promise that we'll just get you prepared for this match cycle, for this marathon people, right? Not for the next, because we cannot do that. That's simple, right? And straightforward. So for you people, I'm just integrating a lot of things. Why? Because yes, it's possible. It's possible, right? So at least you can have like 2 research publications till then, especially in the meta-analysis. And another thing which our team have decided that the authorship would be given, like the first author, to those individuals who are contributing more, right? So here we are not here to, you know, like some of the communities you guys know in the research, they sell authorship, right? But here we have clearly mentioned those who are participating well, they'll be given the authorship, right, based on the numbers. And that's also important, the first author, second and third. It's also important during your match process, right? So please do participate in that. If you guys want to be prepared for this match cycle, right, you guys should be carrying research along with your things, because as I have promised you guys that I'll just get prepared you guys for this match cycle. So it's not only about step 1 and step 2, right? Because you have to take research along with that. So don't worry about that. Once you guys are like right after this marathon, what I'm planning, I'll just wait like for 2 weeks, right? You guys just give your step 1. I'll be waiting here, and right after 2 weeks, once you guys are like done with your step 1, we'll be starting marathon for step 2. Just get ready for that as well, right? So inshallah, I'm expecting all of these 61 people to be there in the step 2, because I believe you guys, we are just, you know, working hard, and this time we are going to crack our step 1, because like whatever, you know, it needs, I'll just do that, right? So we are going to have like complete entire revision in the second phase. We won't leave a single thing missed. Like I already know we have like some pharmacology which we didn't do in the last marathon, right? In the last platform, right? I'm promising you guys that we'll be doing that as well in the revision, right? Still the pharmacology here is also left. And some of the tasks I'll be just giving you, like for example, the physiology of MSK is so small, right? So you guys can just do that by your own. Is it clear? For the pharmacology,
yes,
tomorrow we are going to cover, right?
Yes.
And I'm just writing down these things. But here we have like research going on, so it would be like quite good. If you guys want to be appear in like in this match cycle, research is must, right? Like at least if you're just contributing more, at least you can do 2 publications. But if you're contributing more in that, right? If you're, let's suppose, giving 1 hour per day or like more than that, so you can simply do 2 to 3 publications. And as most of you guys are old graduates, you guys need that, right? And soon the next step, let me just reveal the next step. We are also planning to, connect you with different hospitals here to have US clinical experiences as well, right? So just get ready for that.
Wow, that's awesome.
Yes, so don't worry, right? What I have, okay, this match cycle will, yes, but I have promised you guys, I'll be helping you. Like I'll just give my 100%.
Sir, you're just the
prepare
best.
for.
We love you too. Thank you so much. We appreciate
Okay,
you.
thank you so much. Thank you so much. And what you guys can do is that if you have like friends, you can just share the poster to them in the group so that like many people can just come and participate in the free webinar. Remember, in the research, I have limited slots, right? Like we can't take like 100 or 200 students. That's simple, right? So we have like till now we have 1 mentor, so we'll be just taking 2 or 3 groups, right? Like 50 or 60 people, not more than that, because to be honest, we can't handle that, right? Because we want you to have a confirmed publication as well in the journal, right? It's not only about like teaching things. So get ready for that and see you. Thank you so much.
Doc,
Thank you, Dr. Ahmad.
Thank you, doctor.
Yes,
Doc,
please.
So tomorrow, since tomorrow will be the webinar, so
Yes.
can we do the pharmacology of the MSK tomorrow and then the boot camp for the next day? Because
Sure. No worries. We'll do pharmacology first, then we'll do the boot camp because I'm also here. You guys are here. No problem.
Yeah, because to both of the things on the same day, it will be very like difficult and it will take a long time, I guess.
Don't worry, Dr. Amis. I'm also going to sit there in the webinar, and again, I'll be there in the boot camp as well. So it's difficult for me as well, but we have to.
Yes, definitely. Yeah.
Dr. Ahmad, this is
Yes,
Shafiq.
please.
Yeah,
Yes,
actually,
doctor.
I have one of my friends. He is a PhD researcher in John Hopkins University. If you like, I can share his contact. Maybe he can help also.
Okay. So actually, like Dr. Shafiq, we just took interview of almost like 50 to 60 people, right? And like we were just looking for different aspects, right? As you know, Dr. Abdullah, he'll be just telling you guys they have a lot of publication, and currently he's there in Mayo Clinic, right, as a trainee. So why like we have called Dr. Abdullah? He'll be helping you guys to publish your research in best journals, right? And Dr. Manahil is going to guide you. Like she was there in a lot of organizations you will be mentioning there. So she's the best mentor. And what Dr. Abdullah is going to do, he's going to keep an eye on you guys. If something is wrong, he'll be just telling, right? So Dr. Like we need our research to get published in best journals. That's the main goal, right? So yes, Dr. Shafiq, if you have a friend, if he can help our community, you can definitely just share his number. I'll just take an interview of him. Like basically what we does is that like me, Dr. Maheen, Dr. Laiba, Dr. Hamza, and 2 more tutors, they just sit and we just interview, right? If he's best for the community, I'll definitely invite him.
Yeah, that's good.
Oh.
Sounds great.
Thank you so much. Thank you so much. Thank you. Have a nice day. Bye-bye.
Bye-bye, Doc. Yeah. Have a nice day.